Thank you very much for this very kind introduction. I have no disclosures to make with respect to this presentation, and I'm very happy with the previous presentations because I think they take a lot away of the pressure on me to explain some issues. I think if we look about flow, then we should not forget that decades ago, this was actually how cardiac surgery started. Those people really had to invent everything. And today, if we would look to this cardiopulmonary bypass machine, the previous speaker was said it looks very complex, just this cylinder. Just imagine how this must have looked to people at the time. But nevertheless, there is almost no monitoring available, as you can see. They really had to do it all by their gut or by what they actually found out by falling and getting up again. Meaning that they started with the normal physiological situation, where they know what was in healthy humans, and very often this was a very small number of healthy humans, what is actually the normal flow, how does the body react. And that's the reason why initially the cardiopulmonary bypass was run at very high hematocrits and at the values we normally would encounter in people who have been under anesthesia. Unfortunately, in the meantime, we kept this cardiac index, which we knew from that time, but we start to experiment, for example, with the hematocrit. We went very low after the introduction of hemodilution, and then we went back up the last 10 years because we realized that extreme hemodilution is also maybe not the best solution. So the question then is, how do we know that we have sufficient flow? And that's a very difficult question because we can have actually a lot of information, but a lot of this information is also indirect. And it was also mentioned, what we normally do is we go to intensive care, we have a look there, and we then decide based upon the markers we have available, based on the organ function, how well the patient did afterwards. Meaning that we can only adjust our therapies once the harm has been done. And I think this was a very clever guy. He was a Dutch surgeon. His son, by the way, is in this room. And he actually was the first to say what we should try to do is to have a sort of a multivariate analysis of what is the risk during the procedure, because afterwards it's already too late and we can just try to correct what we did wrong. But then the big question is, and especially at the time when he proposed this statement, which parameters are we going to use? Because not a lot of these parameters are continuously measured. So one of the big problems, and that was mentioned by the two previous speakers, is what is the inflammatory response? And can we really say that this is exactly the same in every patient? Well, if we use the original definition of inflammatory response, then we should say, because this was based on sepsis patients, that 90% of all our patients actually are developing an inflammatory response, which we all know that this is probably not true. So we have to step away, and I think this new concept, which has proposed a few years ago, the so-called PIRO concept, might help us. What does it mean? You start with a given patient. And that's important because there will be a difference in a patient who is actually presented with already a reduced renal clearance compared to a patient with a perfectly normal renal function. So that means that the predisposition of a given patient is an important aspect. The second will be the insult. It makes sense if you have a very small child or you have a very complex procedure that this insult probably will be much more pronounced compared to a more elective surgery where you just have, for example, a few bypasses with a perfect normal left ventricular function. And then we know that based on this insult, there will be a response. And the response, again, are all these markers. But we have to be very careful because those systems need to be in balance. Very often you can see these very nice presentations where people say IL-6 was so high, and because of that we actually decide the inflammatory response was very pronounced. However, we have then no idea what was the anti-inflammatory reaction in that patient. So we really need to have everything in balance, which is not so simple to do. But we can use, for example, lactate as a surrogate of what's happening after the insult. And then finally, the real test will be how will be the organ function, not only immediately after the operation, but also in the rest of the hospital stay. So this means if we are going to look to flow and cardiopulmonary bypass, that we can actually try to define which are the major insults which we are going to put to a patient. And the first will be indeed the type of procedure. We can see, and you see in the first column, are patients which have developed no AKI. The second is actually the group which developed AKI. And you can see that in the second group, there is clearly a difference when you have OPCAP compared to cardiopulmonary bypass. A second group of insult is actually related to pump time. So apparently, the longer we keep them on pump, we seem to have a more pronounced insult. A third one is hemodilution and the type of fluids we are using, because it's not only the hemodilution by itself, but probably also the composition of the fluids we are going to use to do this hemodilution. And finally, as we have seen in the first session, there is a clear impact of the amount of oxygen which we are delivering to the patient. So why is this all related? Because we cannot see the heart as a single organ. And we all know that, for example, the heart and the kidney are one unity. That means if you would have a reduced ventricular function, what will happen is that the cardiac output will go down. The kidney will, of course, get hypoperfused, but as a reaction, it will stimulate the sympathetic nervous system, so it will increase contractility. It will actually increase the renin-angiotensin-aldosterone system, which will improve preload, and so it can compensate for this function. Unfortunately, we replace this interaction, we disrupt the interaction, because now it's the perfusionist who has to sense whether the kidney needs to compensate, yes or no. And in addition, we are increasing the insult by the inflammatory reaction, by hemolysis, by a lot of disruption of tissue. So that means if we are going to look to the oxygen delivery, and I know Marco Ranucci has extensively talked about that we have to keep in mind that it's mainly based on two factors. But that's also a little bit dangerous, because then you could say if I have a very high hemoglobin, then I can still have a sufficient DO2 even with a relatively low flow. Is this true? This is an open question. So it means we really have to focus on both. But what we did in the past was mainly looking to the hemoglobin content, because we were so convinced that this fixed cardiac index, which we were using for decades, was no need for change. So if we look to the hematocrit, we all know that if you have a given hematocrit, you go below a certain level, and that level will depend, for example, on the hypothermia used during the procedure, that you will get an increase of renal failure in that patient. But it also has an impact on all the other organs. Now, I have always a little bit of a problem if we are using these generalized numbers, because we know now that we have a given DO2, which we probably should use, but the question is, this is the reflection of what's happening in whole of your body. So we have to be sure that also at other levels, we really can keep the body in a good condition and the organ function not in a situation where we actually get into problems afterwards. And this will highly depend on the organ. What you can see here is, for example, the heart. The heart will tolerate very low oxygen delivery and still be able to function. And this is because it will shut down a lot of the other organs in order to make this possible. In opposition, we have the kidney. The kidney doesn't tolerate very well a low oxygen delivery. And that's the reason why it's the first organ which is starting to fail in all of our population. And it means that even at the value of about 30%, you already have a slight reduction of the potential harm. And then we have other organs like the intestines, which are somewhere in the middle. And so we have to keep in mind that if we see those generalized numbers, they not necessarily reflect what's happening in a typical organ. And Marco Ranucci was the first to mention that, because I think he did a great job. He was the first to say, do we really have to focus mainly on this hemoglobin? Because we have the flow as a second variable, and that means that you could also say it's not the minimum hematocrit. In his group, 26%, because he worked at a higher temperature than the previous author, but it could also be about that 280 milliliters of oxygen per minute per square meter. And then the question is, okay, if that's true, what is now the importance in flow? Because there are many aspects. We know DO2 is hemoglobin and flow. So as you can see, even if you have the same flow, then the difference in hematocrit makes also a difference in the occurrence of AKI. But what is very important is that we can reduce this value, which is the normal value published in many journals, down to this value just by increasing flow. The question then is, what is this value of both of them? Because apparently there is still an impact of hemoglobin. Should we go further in this? But we do know that we can reduce morbidity. And that's an extremely important message because to my knowledge, it was the first paper to show that a perfusionist is able to modulate the morbidity after cardiac surgery. And this was very nicely shown in this paper. These people were very concerned about all these publications on low hemoglobin and increased morbidity post-operative early. And so as you can see here, they have two groups. One has a higher hematocrit, 25, the other has a low hematocrit. And if they look to the morbidity, they were surprised because they didn't see that difference. They didn't see that at a certain level, their level of renal failure was increasing. And then the question is, why is this? And it's very interesting because the study supports the previous slides in that way. They use an extremely high cardiac index. I'm not aware of many centers using 3.2 liters per square meter in adults. And meaning if we make the calculation that even in the low hematocrit group, they still have sufficient DO2. And this proves that we actually have a tool when we have a patient where we have no blood available, when we have a patient where we actually have sufficient potential to flow high, that we can prevent a lot of the morbidity afterwards. And this was then further investigated. Marco was the first, and I think, like I said, it was a landmark paper in my view. We tried in other centers to replicate it. This study was a first study where we actually looked retrospectively in high-risk patients what would be the impact in a group compared to a higher DO2 and a lower DO2. It was retrospective, it was not prospectively randomized, but as you can see in our center we have about any form of AKI, an incidence of 30%, which fits well in what is published worldwide. But if we can keep this DO2 higher, then we can reduce it by more than 40%. This is massive, because it means there is a lot of cost involved also in keeping those patients on intensive care. So for us, this was a very important message on one hand, and on the other hand, we are convinced that this is the way to go. Today, and maybe because I was a little bit late in his presentation, Marco has presented that to you, we have a prospective randomized study where actually the results are confirmed and which hopefully will be published soon. But it means if we are looking to DO2 alone, we still have this problem, what's happening in a particular organ? For example, in a patient who has a predisposition, severe metabolic syndrome, for example, severe atherosclerosis. Well, if we look to the microcirculation, we have to keep in mind there are two main limitations. Number one, you can see here, this is a convection limitation. That means when you have a low flow, the amount of blood is not renewed very fast, and so not a lot of oxygen is actually delivered. And the lower the flow will be, the higher will be the risk for complications. This can be because of pump flow, but it can also be because you have a lot of edema, which is actually compressing those blood vessels, and because of that reason, you get a mechanical obstruction. On the other hand, we have a different limitation, which we can call diffusion limitation. And that means if we hemodilute a patient, even if we maintain a very high flow, this blood cell has to deliver the oxygen over a very long distance. And we do know if we have a low viscosity at the same time, we are going to lose a lot of these capillaries. So not only we have a diffusion limitation because there are not a lot of cells available, but we also have a diffusion limitation because the number of capillaries is reducing in time. And this is the cartoon of that. You would have the capillary. What you see here would be the normal tissue cylinder, which depends on that. This would be what's happening when you have, for example, a severe hemodilution or a low output. We are losing part of the capillary, so the tissue cylinder becomes bigger. And then we see that the diffusion limitation is mainly important at the end of this capillary. But what is even more important, at the same time, this will start to go to an anaerobic metabolism, and it will start producing carbon dioxide. And this is important because we do know there is not a very good relationship between oxygen-derived parameters and a jeopardized microcirculation. That means that if we disrupt the normal respiratory quotient, where we have in general about 250 milliliters of oxygen consumed and 200 milliliters of carbon dioxide produced, and we would see this type of sudden overproduction of carbon dioxide, that we could conclude that there is a high probability that somewhere in the body we do have a jeopardized microcirculation. But if we look to that, it's not, of course, everything. It's a very important parameter which we should all try to bring into our practice, and especially the combination of DO2 with carbon dioxide production. But what is as important is, even if you have flow, you need a certain pressure to keep the capillary beds open. That means we cannot see flow independent from pressure. And I think what is a very important concept, which was also shown by one of the previous presenters, is can we maintain in a child, in an adult, the autologous regulation? And if we want to do that, how should we do that? Well, the big problem is that we had always the idea that this autologous regulation, that this platform, which you can see in blue, that it was quite long. We see now that this platform is much shorter than we believed previously. So meaning that once you're here, this is fine. There is no direct relation between pressure, or flow if you want, and actually the saturation inside the brain. But if we actually disrupt this, there would be a direct reaction, then we do know that something is wrong. So apparently this method seems to be quite interesting. Unfortunately, it's not available online right now. You have to do it offline, which makes things a little bit cumbersome. But based upon that, we can make some very nice conclusions. Number one is, if we are going to look to a given patient, what you can see here, this is his pressure. So apparently, his value is about is not moving in this area, so that would be the ideal autologous regulation for this patient. That's too simple. It's the same as with DO2. It's not only the absolute value, but also the time you actually expose a patient to this not normal condition. So what they also did, they calculated the time the patient was in this region. And they found a very good correlation between the time the patient has been in this autologous regulation and the amount of major morbidity encountered post-surgery. So meaning flow will depend on the flow by itself, it will depend on the pressure, but it also will depend on the time you actually expose a given patient to flow. And our group was very interested to understand then what is the priority. If you get into problems, what is the best solution? So what we actually did, we took a patient where we had a sufficient DO2 at a flow of 4.5 liters, in this case, for example. What we do is we are going to lower by a drug the pressure, and as you can see, there is no impact on the cerebral oxygenation. So meaning we are in this autologous regulation. Now what we do in here is we are going to reduce the flow by 20%. And as you can see, without giving anything, we see that both the cerebral circulation and the pressure are going down. And then the normal reaction of a lot of clinicians is, okay, we will pump up the pressure. So we are going to give, for example, phenylephrine. That's what's happening here. And of course, you have a very nice reaction. The pressure is going up. But as you can see, the cerebral oxygenation is even going down further. Most likely because we have a very negative impact at the microcirculation in the brain. And then we have another group where we still have some open questions, which apparently seem to have a positive effect. So if you increase flow or pressure, you seem to increase also the cerebral oxygenation. And that means if we have to make a conclusion, number one is for sure flow. Flow and DO2, that's number one. But it is not to be seen without pressure. And that pressure should mainly be in the autologous region. So we come back to a sort of an individualized perfusion. So what are the conclusions? I think adequate flow certainly depends on a minimum DO2. And we still have some great challenges in the future. Mirella Beaujean has shown us that in children, for example, we have no clue what should be the ideal value. So I'm very happy to see that now some centers start to define the best threshold in children. We also have to understand that the microcirculation probably is not completely reflected by DO2, because also our own experience is that sometimes you have sufficiently high DO2, but nevertheless you see an increase in lactate. So maybe we still are not able, under those conditions, to have an optimized microcirculation. We should still work on this multivariate analysis. We should have machines which actually give us you're in a safe zone or you actually transition towards a more risky zone. And then finally, the children I already mentioned, that will be the big challenge because it's a non-homogeneous group. We have seen that in the previous presentation. There are blue children, there are non-blue children, there are monoventricles, there are actually complete repairs, and there it will be extremely challenging to define what is the best flow. Thank you very much for your attention.
Thank you very much indeed. Excellent. So I'd like to open this up for discussion. Any questions from the floor? Just, if I may start, it's picking up on your last point about children, of course, and the thing in congenital we always say is you can't normalize the patient to a standard. And how ultimately are we going to do that? Because every person is their own normal in congenital, and particularly when we look at hypoxia. So any thoughts on how we should be perfusing and protecting those patients optimally?
It's a very good question, and it's difficult to answer, of course. But I think what might be part of the solution under normal situations, if we have in very small children the possibility to measure NIRS at the kidney and at the same time at the cerebral level, we normally have, under normal conditions, a higher value on the kidney. So one of the solutions could be to maintain this higher value throughout the whole operation, because it would mean that you do not shut down part of the body, because actually it's one unit. So the moment we would see that it's going down, it would mean that this feedback mechanism is disrupted. But it's just a thought which we still have to work on.
Okay, thank you.
Thank you very much for a very good speech. I just wondered, there's a lot of open questions, as you said. How should you treat pediatric patients, and which values should you use? Now, if you find out which values are the best ones, do you think there will be a lot of individual variation, that meaning that you need to measure things during the perfusion, or do you think you will gather knowledge that you could apply on everybody and making it simple again? So, for example, that you could say, if you stay above a certain value of flow, then you will always be safe. What are your ideas about the future in that research field?
I think there certainly will be cohorts. For example, there is no way that there will be a relationship between deep hypothermia and children who remain during the procedure under normothermia. Only alone for the reason that if you go to a deep hypothermia, that the oxygen transport is mainly dependent on solubility. So it's no longer the hemoglobin because it's a very firm bond. So that means that also hyperoxia in that case could be beneficial. And we have to keep in mind and to think on how we are going to define that. If you just reduce it to the normothermic procedures, there might be probably a difference between non-blue and blue children, but probably there the differences will be smaller. But like I said, it's still open, and I really do hope that especially the large pediatric centers will try to define for all of us what should be the best values.
I have one more question. It seems like autoregulation and monitoring that is such a major important aspect of knowing about cerebral circulation. Do you have any time frame where you think that might be available in the future as for online monitoring in the operating room?
I have no direct answer for that. I think it depends upon the industry. And we can also question if we are really satisfied with only the cerebral saturation. Because, for example, that does give no information if there would be congestion. And especially in children, where you often have very difficult access to vessels, I would be also very interested to detect when there is congestion. because like I showed you, it could be a convective limitation at the microcirculation by mechanical issues, the pump, but it could also be because you have a lot of edema and you're compressing those vessels. So we really have to have also information. For example, Hamamatsu gives you indirectly some information because you can see how the hemoglobin content is going up or down, and it would go up if you have congestion.
Thank you. Thank you very much.